Started with our last session of the day. My name is Jenny Winkler. I'm a director at the Illinois Health and Hospital Association, and I'm very lucky that I get to introduce our presenter, Dr. Justin Moore, who's the coordinator for the Antimicrobial and Diagnostic Stewardship Program and an infectious disease clinical pharmacist at Northwestern Medicine. So Dr. Moore's role focuses on diagnostic stewardship, infection management in immunocompromised patients, and clinical outcomes research. And so we are so excited to have Dr. Moore share with us more about NHSN AUR implementation.
Great. Thanks, everybody. Can you hear me fine in the back? Okay, just want to make sure I'm not screaming. Since we're a small group, this will hopefully be kind of a workshop, so we can make this as informal as it needs to be. If folks have questions, feel free to stop me along the way. But hopefully this will be something that you can use as maybe a guide or a toolkit to better navigate NHSN and all things antimicrobial use and antibiotic resistance reporting. So here are the learning objectives. I'll give you a second to look at those. Just of note, I have no disclosures to report. Here are some abbreviations that I'll use throughout the presentation, most of which are probably familiar to you, but especially the NHSN specific ones. Be mindful of those and we'll review them again throughout the talk. So again, smaller group, just to get a sense, kind of who's here. Maybe raise of hands for roles first. So infection preventionist. All right. ID pharmacist, stewardship pharmacist. Okay. Any physicians in the crowd? No. Any informatics, hospital leadership? Who am I missing? Okay. Great. Perfect. Okay. And then experience with NHSN. So is everybody currently at least familiar with NHSN or have some experience with uploading data? Okay. Is anybody maybe uploading data for the first time this year? Raise of hands. Okay. Anybody been uploading data for 3 or more years? Okay. And then everybody else maybe just wanting to learn more? Is there anybody not directly responsible for uploading or kind of managing? Okay, great. Cool. So we've got a good mix. We'll focus again on kind of from tip to tail in terms of what NHSN is, why do we care about it, how to actually upload the information, and then how to leverage the data once you have it. We've covered this. And then specifically, so we'll talk about vendors. Anybody using Epic? Okay, so maybe about half. Other things like Vigilance, Meditech, okay. Anything else? What is Premiere, I guess? What are you using? Cerner, okay, cool. All right, well, that's a good starting place just to kind of level set the room. So today we're going to talk about, again, really the kind of nuts and bolts of all of this, but the purpose of NHSN, so why do we do it for both AU and AR? Really the value to your institution and to your potential stewardship and infection prevention programs, as well as hospital leadership kind of values and stake in this. The process, so looking at kind of, again, the logistical pieces of this, how to become set up with NHSN and really make sure your data is flowing smoothly, and then just having a better understanding of kind of what it is and why it matters. Then the impact, so maybe how to leverage the data that we put into NHSN to cause practice change at your site. After putting this together, I realized it spelled out PPI, so I'm really hoping that after lunch and the dryness of this talk, I'm not giving anybody heartburn here. So just a nice pharmacy joke there. But starting off with some of the background and rationale. So here, the NHSN is part of the patient safety component, which houses the antimicrobial use and antimicrobial resistance modules. So AU was developed in 2011, really to enable benchmarking for stewardship. AR was developed a few years later in 2014 to enhance that awareness around resistant pathogens and really optimize clinical decision making. As you can see here, so there's been an uptick over time, especially around the year of 2017. And as of 2023, there were about 2,700 facilities reporting data to AU. I believe this morning on the call, Melinda was saying 3,800. So that may be part of this recent mandate from CMS. So we'll be interested to confirm that figure. But the more facilities that put data into this program and these modules will able to learn more and have more generalized information to better understand and benchmark our antibiotic use and our resistance patterns. So earlier this year, CMS actually mandated that facilities report both AU and AR as part of the Promoting Interoperability program, as part of that public health and clinical exchange objective. So this is a mandate for both acute care hospitals and critical access hospitals. And the big piece of this is, why should hospital leadership care? It's because it's financially tied. So you must meet these EHR reporting measures to avoid decreased CMS payment adjustments and reimbursement rates. And reporting to AU and AR. You heard my horrible joke. And again, we care about this because it really is tied to financial kind of implications. We also see this move from regulatory bodies to really emphasize and promote NHSN reporting for both AU and AR. So this is something that you're probably familiar with, but looking at the core elements. So as we saw this morning, a lot of institutions are doing a pretty good job with the kind of basic core elements. And that led to really this enhancement from priorities of these core elements. And as we saw in the Illinois area, it was about 10% or less really said that they adhered to these priority elements. One specifically that we care about is this tracking measure. And the prioritized element here is really that you are and your institution reporting data to the NHSN, specifically for AU. So this you can think of as really a best practice. So what should we be doing kind of from a stewardship and infection prevention lens? Additionally, Joint Commission has similar kind of suggested language, but this is from one of their elements of performance 16, which really says you should be tracking your antibiotic use. So whether you're using days present or patient days, or you can fulfill this EP by just reporting to AU. So this is something that you can, easily check off just by being compliant, and it feeds a few birds with one stone. Effective July of this year, so about 2 weeks ago, this does not apply to NHSN AUR. However, it does apply to other things within the kind of patient safety network. But acute care hospitals are going to be required to join the Joint Commission NHSN group to evaluate safety and quality performance. So that'll apply to some of our healthcare-associated infections, things like CODI, CDI, CLABSI, surgical site infections, and then MRSA bacteremia. So there is the potential that, as we're sharing more of this data, AU and AR may be potentially something that's included in this as well. For now, this is limited to acute care hospitals, but critical access hospitals could be involved in the future. Otherwise, like we talked about, so really this allows us to kind of inform trends for use and resistance. It gives you the ability to compare data within your institutions. You can look at different wards or different units. You can also compare different institutions within one health system. Again, the risk adjustment here, I think, is the large benefit, because the raw data, I think there's so much variability in terms of different prescribing habits, the severity of patients, kind of what the case mix index is. And then we also have the ability to look at percentile ranks. So we'll go through those in a little bit. This also allows you as a stewardship leader to really kind of prioritize interventions and figure out where you need to emphasize education. So you can pinpoint, okay, we've got excess MRSA activity and antibiotic related use. We probably need to either work with infection prevention or target prescribing clinicians to make sure that we're not using vancomycin when not needed. The other piece that I think is really beneficial from reporting to AUR is that enhanced transparency and potential information sharing. So within regions, states, partnering with local or state public health departments is something that we should be able to kind of leverage more, because we need to know. So knowledge is power. Getting insight into this is going to be important to be able to identify and understand the problem. That way we can potentially solve it, especially when we're talking about the threat of drug resistance. This is the CDC updated threat. So this actually came out recently. You'll note the changes from 2022 really across the board. Looking back 3 years prior, we see increases among things like our carbapenem-resistant Enterobacterales, our carbapenem-resistant Acinetobacter, MRSA, VRE. So all of these things are at least stable or worsening. So this is something that we can't ignore. And AUR is one tool that we can use to kind of better track this and identify problems locally and kind of throughout the US and world. This is what I was talking about largely with hospital leadership. So because it's tied to financial implications and there are growing mandates from regulatory bodies, they should be paying attention and they care about this information. So this could be an opportunity for you to leverage support, be it informatics, IT, extra liaisons with the microlab. These things could help you, I think, have a better relationship with AUR. And once you kind of describe to them the implications in terms of the negative reimbursement rates, that's something that adds up quite quickly. So if you're looking at about 1,000 discharges or admissions per year, maybe you're talking about hundreds of thousands of dollars. Once you're into the tens of thousands, you're looking at millions of dollars. So this is, not small potatoes. So once you kind of share that information, A, they should probably already be aware, but B, I think you're going to find that you get support quite quickly. From a stewardship lens, again, really ability to kind of identify those problem areas and address them. And then it also allows you to set some guardrails or triggers for intervention. So we can talk about both the SAR, which we'll get into in a bit, and then the percentile ranks to compare to other sites or compare units within your institution to say, hey, this is an outlier, maybe we need an intervention to target that. In terms of quality and safety, so especially with AR, it's something that allows us to do more real-time tracking, and it gives you the baseline information to potentially leverage it into something within your own institution that's homegrown, be it a dashboard or some reporting system that allows you to more longitudinally monitor kind of these resistance patterns, inform like outbreak potentials and infection prevention responses, and then really optimize care. That's what we're trying to do here. So slowing the threat of resistance and really improving patient outcomes. So AUR is, again, another tool that we can use to make that happen. So this is, I think, the most detailed part of the presentation. It really gets into the process. So for those who are already familiar, apologies. But for those of you who are just trying to kind of speak the language and learn more into how this works, hopefully this will serve as kind of a guide or a toolkit for you. The one thing, so NHSN has amazing resources. So like I said, they have dozens and dozens of these how-to videos. Some of them are a bit longer, about an hour, 20 is I think the longest one. And then they have short clips, so like 12 to 16-minute videos about specific things. So if you're having issues with how to upload data or how to run a certain report, you can find all of that on the website and or YouTube. So that tailored support I think is really, really helpful. So start there if you have any issues. If you wanted that more generalized approach or you're trying to educate your teams, I think there's one document. So they have a protocol, which is really step-by-step kind of all the information that I'll cover today and what you need to know. And then they also have a roadmap, which is really nice. And it kind of builds stepwise. So you're really starting with the foundational basics and then working up to those more advanced reporting systems. In terms of requirements, so I think everybody is maybe doing this, but just as a refresher, so in order to report to AUR and participate in the modules, you do have to have kind of information easily transferred. So administration info, be it either a medication administration record or an EMR or barcode scanning, so BCMA. You also have to be able to kind of figure out where patients are moving throughout the hospital with that location mapping. So you have to have some system for admission, discharge, and transfer. And then with that AR component, we do have to have antimicrobial susceptibility results. So using that lab system information and or information system and or the ability for it to talk to your EHR, those are going to be essential. So that's what we were talking about before. If you are at a facility where you send off cultures and you get it back as a fax, so it really doesn't speak to your EHR, that's one area where you'd probably have significant issues uploading the information to AR, and that may kind of disqualify you from participating. So there have been some murmurs maybe that CDC will reevaluate whether AU and AR will both be mandated in 2025, or if there's still kind of a significant percentage of facilities that aren't able to really adhere to that AR mandate, and whether that'll be, again, kind of tied together. So the vendor discussion, so again, it seems like a lot of folks are on Epic, Cerner, maybe a little Vigilance. The reason why we do this is because this is huge amounts of data. We need to make sure that it's validated and it's kind of in the format that we need it to be. So it should be in these clinical document architecture files or CDA files that are in this HL7 or Health Level 7 standardized format. It's really coding So it looks very different and not super user-friendly for those folks who are maybe less familiar with coding, and or it's not something you would be able to interpret from just like an Excel file or manually enter. So note that you're not going to be able to just plug in, okay, we used 1,000 doses of meropenem this month on this unit. That's something that you would not be able to do with an NHSN. This is where kind of forming your team is important. So identifying your NHSN administrator, I think at most sites it's probably an infection preventionist, but making sure that you and kind of the necessary users are enrolled. And then mapping location. So this is something that's essential and you'll have to look at constantly, it feels like. But that monthly reporting plan for both exporting and uploading information, the data has to have kind of a proper flow from your EHR vendor to NHSN, both at the facility-wide level and the location level. So location-wise, we have 8 adult locations. So they vary med-surg. You can have a mix. You can have oncology and heme wards. You can have ICU and adult step-down units. So these are just a variety. And then the combination of those, again, form 8 adult units. I didn't include peds or neonatal, apologies, but if you want additional information, that's listed in the link here. And then outpatient, the 3 adult ones, or the 2 adult ones, excuse me, and 1 peds that really come up most often are going to be the emergency department, any 24-hour observation units, and then the pediatric ED. So implementing AUR, so again, these are going to be separate reports, but a lot of the information is very similar. So you'll be using a lot of the same sources and kind of making sure that it's feeding into the upload system the same way. And so we want to make sure that that information matches. I think the biggest piece and kind of headache that we have maybe every few months is location mapping. So if you had a unit close or a unit name change or the population is updated, we saw a lot of this with COVID. If something went from an ICU to a medical ward, but you're still reporting it as an ICU, you would probably expect that you're going to be using less antibiotics or antimicrobials in that case. And so you want to make sure that it's mapped appropriately so we're not over under reporting when we're comparing it to like locations at other centers. So that is one to definitely discuss with your administrator. I think this is where you befriend IT. They will help tremendously to make sure that data flows appropriately. And then again, I think we covered you need the information from your MAR and the lab to make sure that all of that is feeding in as necessary. This is where if you just wanted to get a better handle on some of the language for AU specifically. So AU uses antimicrobial days of therapy. So this is kind of summary level aggregated data that's performed on a monthly basis. So anytime an administration is documented, that would count as a day of therapy, whether it's 1 dose, whether it's 10 doses. So it's any dose of medication on that day is counted as that day of therapy. It's not able to distinguish if they received, again, 10% of the scheduled doses, 100%, so keep that in mind. So we may be over-reporting the days of therapy with this measure. However, it's been kind of chosen to be preferred. This includes almost 100 agents across various routes. So intravenous, intramuscular, digestive, so either oral or rectal, and then inhaled. This does not include things like topical. So just be mindful of that. But there's a range of agents, so antibacterials, antifungals, antivirals, and I'll show you some of them throughout the presentation. But the full protocol to kind of break this down is available from NHSN. So all of that is going to be in our numerator for AU. And then our AR, you could have, or excuse me, our AU denominator, you could have 2 options, one of them being days present. So this is going to be the number of days which a patient spent any time in a location. So if they were there for a few hours and then transferred, that would still count. We'll talk about how that differs with AR. And then if it's done, it can be performed for the facility-wide, it can be done for various locations or departments, and for the outpatient setting, so ED or 24-hour observation. You can also look at antibiotic days of therapy per admission, so the number of patients admitted to that inpatient location. However, this is facility-wide only. So just keep that in mind when you're trying to kind of tease your reports out. This is an example to walk you through how to calculate antimicrobial use. Days of therapy, so we see here patients treated with meropenem 1 gram every 8 hours and amikacin every 24 hours. So ignore that this is maybe an outdated recommendation, and hopefully we're not giving repeated dose of amikacin too often. But here you can see that, the patient started kind of late in the evening on Monday, December 28th. They got 1 dose of meropenem, and that's going to count as 1 antibiotic day for that meropenem. Same thing with amikacin. They fulfilled their entire kind of daily quota there, so that 1 day is going to count as well. Same thing, Tuesday, we see doses of meropenem and doses of amikacin given. However, on Wednesday, antibiotics are stopped, and we only see 1 dose of meropenem given. So we'll count that day for meropenem, but no days for amikacin. So total, you would see, 5 days of antibiotic use here. So if this gives you a sense of how to kind of approach it. So it's any receipt of an agent as documented per administration records. This is where I think folks, especially outside of this space, and when we're talking to hospital leaders, start to glaze over and really get confused by what the heck is a SAR versus a SIR. Just give it to me kind of in plain English. But our SAR is going to be that standardized antimicrobial administration ratio. So it's going to be looking at kind of our observed to predicted. So observed in the numerator, predicted in the denominator. So predicted is going to be based on our expected days of therapy using a predictive model. So we talked about this before, but CDC uses baseline standards, so 2017 data from adult and pediatric AU reporting to figure out for each antimicrobial agent category, which we'll touch on in just a second, which factors need to be maybe at risk adjusted and what's the magnitude of those. So you can see an example here. This one's for hospital onset infections, broad spectrum agents. So things like whether patients in the medical ICU versus a step down ward. Obviously a medical ICU, you're gonna expect more use. So the magnitude of that risk adjustment is gonna be greater than if they're on a step down unit. So you don't need to know this by any means, and your vendor will be, again, giving you the information appropriately. But this is why the mapping matters so much, because we want to know where they're coming from, where the data is collected, and then which antimicrobial agent category it belongs to. So NHSN does a ton of the work here, but again, it's essential to make sure it's appropriately mapped from your vendor. There is an expected update. So in 2025, we expect that the predictive models will be adjusted again based on 2024 reporting. So look forward to that. So again, as more institutions kind of contribute to this, we'll be able to better inform this model. For SAR, is everybody familiar with SAR already? Ish, okay. But if it's a ratio, right? So if it's greater than 1, it's going to be more use than expected. If it's exactly 1, it's kind of at the rate that's expected. And if it's less than 1, it would be fewer or less antibiotic use than expected. This does not have the ability to tell us whether that's good, whether that's bad, whether things are appropriate, whether that's inappropriate. So you're going to need to put this in context. So all it can tell us is more or less. The various SAR reports that are available can look at agent class. So again, whether it's kind of broad spectrum, whether it's narrow spectrum, and then depending on kind of what it's planning to treat. So we'll touch on that in the next slide. There are going to be cases where, you wouldn't expect that you want greater than expected antibiotic use. But if we're talking about narrow spectrum agents for the right indication, maybe that's a good thing. So again, that's where the context is really going to come into play. These are some of the SAR categories, so those agent categories, and forgive the pun here, but all antibacterial, so this is really going to be all antibiotics. So you see some examples, amoxicillin, meropenem, vancomycin, so really any agent really spans the gamut in terms of spectrum, gram-negative, gram-positive, broadness, etc. Then we have our broad spectrum community acquired bucket. It's going to be things like ceftriaxone, Cipro, ertapenem. So again, this may be, you don't necessarily agree that something's broad versus narrow spectrum, so it's all in the eye of the beholder, but this is kind of agreed upon by a group of experts at NHSN, and I think most of it aligns with general practice standards. Hospital onset broad spectrum, so these are going to be things like cefepime, piptazo, meropenem. Of note, these are just some examples. This is not the exhaustive list. You can click this link and it'll get you all of that. And you'll also notice that there is some overlap between categories. So for example, ceftriaxone is featured in the broad spectrum community acquired and the risk for C. diff. But all of these are kind of our available categories that you would be potentially exploring in the SAR reports, including antifungals. And this is when it's really our azoles and mica, so we don't include things like amphotericin. Similarly, when we look at the all antibacterial category, we don't include some of our newer agents, things like cefiderocol, Emirel, Mirobaber, Solder. So over time, as we're using these agents more and have more reporting happen, I would expect that they'll be included in these SAR reports. In terms of uploading, so this is always something that I think varies site by site, but it's recommended to upload within 30 days following the month completion. So I think best practice here, just come up with some standard process. So if it's a calendar reminder or a to-do list, if you can get the same person to do it, great. Maybe like within that first week to 10 days of the month, just having a reminder for yourself, okay, I need to upload NHSN data. We find that, you know, when you hit a snag or you run out of time and then all of a sudden you have to upload 6 months of data, that's pretty painful. So I think the gradual uploads throughout the year make it a bit more manageable. So you will be uploading one CDA file for facility-wide and for each department level. That would include all inpatient units, ED if you have it, and a 24-hour observation if you have it. So be mindful of that. It's essential to really perform some validation. So once you upload, you'll get a report of, you know, 24 of 24 units were accepted or 20 of 24, whatever it may be. So just check what your errors are. Again, you want all of the information to be transferred accurately and appropriately in order to get meaningful data back. And this is really where informatics and analysts can help, especially if you have troubleshoot issues or errors. Sometimes it's as simple as, you know, you forgot that you already uploaded it. We try to upload again and it's a duplication error, or we can't really figure out what the error is. I was saying earlier, but NHSN sometimes feels like a bit of a black box. So then it's just, you know, removing prior uploads and trying to re-upload, and that's been successful in the past. They also have office hours if you have specific questions, so check those out. And then CDPH is offering some office hours in a working group as well. So this is some of the output that you can get from AU. So it's an exhaustive list, but I've kind of broken it down. So the SAR report I think is most useful. Again, that's going to be risk adjusted based on that 2017 baseline, and then give you the ability to see kind of, you know, where you stack up compared to others. The rate table is also helpful. So this will look at days of therapy over either patient days or admissions. And then our line listing. So this is going to give us specific agents, specific units, and time. So if you wanted to do a deeper dive or, you know, your own manipulation of the data, I think it's nice because you can really tailor it to your needs. Some of the visual representations I think are nice. We don't use them as often. I think we more so kind of use that line listing and then really craft it into more impactful ways to represent it. But they have pie charts, bar charts, etc. So this is the SAR reporting. So you can see it gives you the month, it gives you the unit. So here we're looking in the agent category. So here we're looking at adult, broad spectrum hospital onset in the ICU. We're using that 2017 baseline, and we see in July, we had 573 antimicrobial days based on the administrations, and then we have the predicted AU days to be 124. So knowing that our actual is above our predicted, we're going to expect that our SAR is going to be greater than 1, and we see that our SAR is about 4.6. You can also look at the p-value, so this will give you, you know, whether it's statistically significantly different than the predicted SAR. A lot of times when we're talking about these, you know, huge data sets and larger kind of upload information that's included, we're going to expect that most of these are going to be significant. So just keep that in mind when you're, you know, sharing it with others. And it also gives you that 95% confidence interval to see what the expected range would be. I think more helpful and what we've really leaned into in terms of leveraging this information has been the percentile rank. So this allows you to kind of get more recent comparisons. So these are updated more frequently and includes facilities with about 9 months or more of data each year. These are available at the department level location, so it may be a little small here. But you can, oh, I got cut off. But here, if this went further down, you could see that, so for the top one, we see that it's a SAR percentile of 69. So this ranges from the lowest percentile, obviously less use compared to other sites, highest percentile, more use than other sites, and that 50th percentile really serving as the median. These ranks, again, are updated on a near yearly basis. I don't think I've seen 2023 yet, but 2022 is available. And this is per location. So again, you probably want to be shooting for the 50th percentile or lower in most of these cases. So this allows you to really inform kind of goal setting a little bit better versus SAR, we don't always know what to do with it because there's so much context needed. So in these cases, again, probably lower percentile rates is favorable. Shifting a little bit to AR. So AR, in terms of the numerator, we look at the isolate, and the isolate must meet kind of the following criteria. So it must be in an eligible location or department. So it's got to be an inpatient unit, ED, or 24-hour observation. Again, this is on the adult side. It has to be an eligible source. So this is broken up into invasive. So invasive would be blood or CSF, and then non-invasive, which would be lower respiratory or, a BAL, or urine. For invasive, I think it is one thing to just remember that we can't upload all this information that would maybe over-report or overestimate our rates. And so NHSN has a limit. So per individual patient, per a 14-day window, since the last positive invasive culture. So we'll go through an example in the next slide to kind of spell this out. Versus non-invasive, it's per calendar month. So one patient per calendar month. So here you could do one in March, one in April, even if it's March 30th and then April 2nd. Those would still be fine to report both for non-invasive. It also has to be an eligible organism. So interbacteriales, non-interbacteriales, or non-fermenters. Some of our common gram-positives like Staph aureus, Strep, and Enterococcus, and then Candida species. We have a list in the next few slides, which will spell that out in more detail, but it has to be one of those organisms in order to be eligible for isolate extraction. And then antimicrobial susceptibility must be performed. So you don't have to report it or perform susceptibilities on all eligible agents, just one, and that would kind of suffice for the requirement. The denominator, so we see slightly different kind of accounting for the patient, how long the patient is on a specific unit or facility. So here we're using patient days instead of days present. And so this is going to be a monthly sum of the number of patients present at a certain time period. So whether it's, say, like 12 p.m. or 12 a.m., whatever your hospital uses to measure that as part of the daily census. And this is performed at the facility-wide level only, so not department level. Versus we still see the admission similar to how we had it for AU, and this would be the number of patients admitted to any inpatient location. Largely, this is also facility-wide. And then the one difference here is the ability to also include encounters. So this allows us to get that outpatient information, so looking at ED or 24-hour observation. However, this does not take into account how long they spend there. So they could spend an hour there, they could spend 2 weeks there. It's really just marked as a single encounter, regardless of how much time is spent. This is really just breaking it down for the invasive species. So again, that 14-day rule. So we see on January 1st, we have a patient with Staph aureus bacteremia. We report that isolate because it's invasive and it's an organism that we care about, and we had susceptibility data performed on it. However, the patient has another positive blood culture with the same organism. So again, invasive source, same organism. We're not going to report it in that case because it hasn't been more than 2 weeks in between that and the last positive. Then on January 16th, they actually have complication with their CNS, and they have a positive CSF culture with that same organism. This is one that I think is not as commonly known, but that would not be reported as well because it's in that same category of invasive, and it's been less than 2 weeks since an isolate that we didn't report. So I think the easy thing to do would say, oh, it was January 1st, it's January 16th, we should be reporting both. But we had an intermittent positive one that wasn't reported. So it looks back to the last one. So that January 16th, January 4th, that was only about a 12-day period. So we would not report that one. However, then 15 days later, they have another positive blood culture with that Staph aureus. So again, invasive, and it's been more than 14 days, since the last positive. So we would report that one. Does this make sense? Again, versus non-invasive, it's really the calendar month that we care about. This is the full list of eligible organisms. So again, you can see really non-fermenters, Candida, interbacteriales, some of our gram-positives. And then we'll get into the various phenotypes as well. So here we have carbapenem-resistant interbacteriales. So a lot of the ones that you see in the CDC report. One difference is probably the extended spectrum cephalosporin resistant Enterobacterales. So most of the time we think of ESBL. However, they do have a slightly different definition, as well as specifically looking at fluoroquinolone resistant Enterobacterales. VRE, obviously common, and then Pseudomonas, there are two different definitions that vary, I think, from some of our guidelines. So quinolone resistant Pseudomonas and then multi-drug resistant Pseudomonas. So again, that's going to be where it's non-susceptible to at least one agent in 3 or more categories. And then MRSA. What we did at NMH, because again, kind of definitions vary slightly, is we adapted these. So we report based on ESBL. So we still use ESBL as kind of our designation. And I'll show you later on how we incorporated all of this into a dashboard report for these multi-drug resistant organisms. But ESBL made sense to us, so we didn't go with the extended spectrum cephalosporin resistant Enterobacterales. However, for NHSN purposes, we're obviously still reporting that same agent category. Carbapenem resistant CRE, we have both carbapenemase, producing CRE and non-carbapenemase producing CRE. So we have that kind of separated out. And then we used a different definition for Pseudomonas. So we actually used difficult to treat Pseudomonas, which is recommended or at least suggested for the IDSA guidance, which is where we're exhibiting non-susceptibility to all of our first-line agents, things like beta-lactams and quinolones. Crab is consistent. And then for our gram-positives, all of these are very similar. And then Candida auris. So Candida auris would be one that is used in both NHSN reporting for AR and kind of our use as well. In terms of the rate metric, so again, think of in AU, we used the SAR report. Here, we're using something somewhat similar. So this is going to be the standardized resistant infection ratio. So this is going to be compared to risk-adjusted 2019 baseline. So this allows us to really compare your hospital onset infection rates to other national kind of comparators. So this, again, looks at the observed over predicted. So I think somewhat intuitive. So obviously, if it's higher than 1, you'd be seeing more resistant infections compared to what's predicted. Lower than 1, lower infections compared to what's predicted. This is for the location level. And then pathogen-specific standardized infection ratio. So this is a new one, obviously, with AR. So this is that summary metric to look at the culture positive that are caused by specific pathogens. And of note, it's a limited menu. So here we're looking at Enterobacterales, Pseudomonas, Staph aureus, and Enterococcus. And it must come from either the blood, urine, or lower respiratory. So CNS or CSF is excluded here. But again, same thing where we're looking at the number of observed infections for those specific groups. So Enterobacterales, Pseudomonas, et cetera, over the number of predicted infections based on the location. These are some of the rate metrics that are also used. So we have these different standards. So for hospital incidence, community onset prevalence, then outpatient community onset prevalence. So it really just depends on where the information is pulling in terms of patient location. And then you see the denominators here vary slightly. So whether we're using patient days for hospital onset, admissions for community onset, or then number of encounters for outpatient community onset. So we're looking at those AR events, so how many times those isolates show up, and then multiply that times 10,000 days. Antibiogram data, I think, is one of the most helpful resources that you can gain from AR reports. So this is one that, very consistent with what you'd expect an antibiogram to do. But this allows you to get facility-wide data on the rate of susceptibility. So it looks at the total number of susceptible isolates over all of those tested, to give you a sense of what your trends are throughout your institution. These are some of our kind of Epic screenshots of what it looks like for us. But again, our vendor being Epic, it's, I think, quite user-friendly. So these are the 2 reports that you would be using. So an isolate review to note or flag, hey, these are the ones that we plan to include. And then our AR events, which get transformed into those CDA files for uploading into NHSN. This is not super important. Yours probably looks consistent, but here you can see this is our facility level report. So these are various hospitals throughout our system. And you can see it gives you things like days present, whether you're reporting, your MDRO rates, and total patient days. So you can see very high numbers here again for full kind of hospitals, especially at a large academic medical center compared to some of our community sites. And then here, this gives you location specific information or department level data. So here you can see various settings. So an ED versus a ward versus an ICU. And we can see that it also gives us information about days present, et cetera. For the isolate review, so again, this is how you would be flagging kind of the isolates to include in the AR events. So I think it's important for you all to make sure that it makes sense. So again, we should be looking for, is it one of the specimen sources that we expect? So is it BAL, is it blood, is it CNS, or is it urine? You'll notice the X's for isolate status. So things like a wound swab, if it's from a trach, those are not going to be included because they don't meet that kind of designation. And then is it a bug that we would expect to be on that list? So is it Enterobacterales? Is it some kind of rare non-fermenter? If that's the case, it would be excluded as well. And it'll give you the reason why it shouldn't be included. So always good just to kind of validate this and make sure that it's consistent with what you'd expect. And then this allows you to kind of mark those to be included for AR events. So once we have the susceptibility information, you'd be able to confirm that. So again, we would see then where's the source, what's the bug, susceptibility information has been collected, and then we're able to export this in that CDA file. That gets uploaded into NHSN. There are two ways that you can do that. You can do manual uploads by users, or you can have your vendor do it. Does anyone have a vendor uploaded process? I don't think it's super common, but I'm always curious, especially if you can take the work out of it.
Yeah, like just like for direct submission.
Yeah.
Everything's through.
Okay, so all of it goes through, so you don't have to log into NHSN at all?
They don't. We will log in, but we don't have to for AU and AR. We don't necessarily have to do the manual process of submission any longer. It's all linked in through Epic, so it just goes directly out exportation.
Okay.
I know the lab will double check to make sure, like you're saying, the validation process. It's going to be more so on the lab side than on the pharmacy side. But yeah, they won't have to do everything.
Good to know.
It's really nice.
Yeah, we've been asking for a bit, and we have like a support log outstanding issue for it. So we're gonna take that back and see if we can get some updates there. Cool. This is the menu, so you can do a lot of things very similar to what you can see in AU, but various reports, line listing. So again, based on what your needs, you can kind of get a lot of information in various ways. This is kind of a roadmap that we've suggested potentially. So really, again, putting together your team, making sure you have the appropriate prerequisites and you're set up well. Partner and find friends in analytics and infection prevention. If you are an antimicrobial steward, or vice versa, if you're in infection prevention, find your friends in ASP. Try to document the process and come up with some tip sheet or step-by-step guide for how to do it, especially if you leave or somebody else takes over. We want to make sure that it's transparent, reproducible, and kind of standardized. The one thing, I think, give yourself some grace, especially at a smaller site with less support. It can be a frustrating process, but use your resources, kind of tap into your network and ask for help, especially for sites that have been doing it for quite some time. I think leverage those experts and make sure you're doing this on a frequent basis. So I'd say monthly or every few months. Monthly is optimal. Every few months, I think, is still doable. Try not to let it go, 6 months plus, because then it's really just going to stack up. And then make sure you're reviewing your reports for accuracy to make sure it's consistent with what you'd expect in terms of your practice. And then kind of make sure this information doesn't stick with you, share it with other users, decision makers, and then kind of repeat the process from there. Knowing that we're a little short with the issues, I'll kind of breeze through this. But this is really how to leverage the information. So this is one of the rate tables. So again, with AR, I think it's some of the output is a lot nicer. So it gives you information in terms of the rates of antimicrobial resistant isolates or organisms. Just wanted to thank everybody listed on the screen here, especially Mike in the room. He laid the foundation and has been doing this for years and years, so it made it a lot easier. But these are some of our partners throughout the process, so infection prevention and informatics. Here you can see AR events, so it's nice because it's very user-friendly. If you were strapped for time and you just wanted to share, these are the isolates that we've seen in a month period or a 6-month period, whatever it may be, you can get this information really quickly and kind of share it with others without much manipulation. So here you can see things like E. coli, Club pneumo, Enterobacter. They're all color-coded differently, and you can see over time as those rates change. So that would be your bar table. This one I think is probably the most useful. So your facility-wide antibiogram. Sorry if it's a little small. But it gives you information about specific pathogen groups and then, common antibiotics that we would use, especially when it may not be always as accessible in your EHR, depending on your kind of lab information system and how much it speaks to your EHR. But you can look at things that are, multi-drug resistant or extensively drug resistant, and what's the likelihood that things like ceftobiprole, but ceftoltazo or ceftazabine may cover. That aren't always included in our standard antibiogram. So I think this is probably one of the things that I would definitely say to start with, because it gives you a nice sense of overall resistance rates within your institution. One thing that we've done is we've leveraged this information into local dashboards. So this is one using that SAR percentile. So here you can see we're looking at all anti-infectives. The dark purple is our active medical center. At the bottom, you see all of our other sites. So we have that aggregated data to really see who's contributing and what percentage of the overall use they're contributing. And then we see trend lines as well. So you can see here we're about at the median. It varies over time, month to month, but we kind of hang around that 50th percentile for all infectives, anti-infectives. And that's something if we saw that kind of increase like we did in August of 22, and that was persistent, that's something that we'd obviously want to monitor and maybe pinpoint if we can drill down to specific agents or specific units that are contributing to that overuse. So again, this is where maybe your SAR percentile is more helpful than the SAR because of that comparative data. This one really just gives our full health system. So it gives us a better sense of, again, maybe some of the outliers within our groups, especially for like institutions. So looking at similar kind of community hospitals with similar bed sizes, where are we seeing upticks, where are we seeing rises in use or decreases in use compared to other reporting centers. So this is something that I think we've really tried to leverage more recently to get a better sense of, what should be our top intervention. This one is something that we extracted from NHSN and then transformed into our own dashboard using Microsoft Power BI. So Jamie Burkowski, shout out here. Sorry, her head got cut off. But this looks at 4 different hospitals and what we would expect with the kind of specific SARs. So this is looking at all antibiotics. You can see we were able to kind of have a trend line, so showing that our system SAR is around 0.9. And then it allows us to kind of track across institutions, maybe who's overperforming, underperforming, and maybe where we need to kind of pay more attention. Similarly here, this is one specific example that we use. So if you're in the room next door for the last presentation, at Northwestern, we had a urinary tract infection initiative where we tried to push people from broader spectrum, 3rd generation cephalosporins like ceftriaxone to 1st generation agents like cefazolin. We really saw that the appropriateness rates increased. So here in the graph, you can see the 2 like purple bars, vertical bars, are the launch of the intervention and then some follow-up education. And you see those trend lines completely flip. So the red being ceftriaxone, the green being cefazolin. However, we weren't really able to show that we had a more broad impact on other agents. So they were like, great, you went from a broader agent to a narrow agent. But did that improve things like mortality? Did it improve things like overall antibiotic use? Did it improve things like C. diff? So we leveraged NHSN and some of the other agent categories to better define that. And that's what you see here. So looking at our narrow spectrum beta-lactam, so that includes things like cefazolin. Around the time of the intervention, a few months later, we saw that increase tremendously. So this is where, a higher SAR is actually good. And looking at community broad spectrum, so this would be ceftriaxone, we see that decrease, and accompanying that, we see C. diff risk, ceftriaxone decrease. So this, I think, points out how you can use some of the NHSN information to really make a better impact at your system, and then it provides that kind of more standardized, risk-adjusted information. So hopefully decreasing the amount of confounding here. Additionally, so this is another example. So I think it's really important to make sure that you're sharing the information. So I feel like we're sitting on this kind of gold mine of data, and we want to make sure that it gets outside of just our stewardship and infection prevention teams. But using this along with your daily tasks and other reports that you have, like antibiograms, to really inform kind of what practices and what interventions should be targeted. So here, this was something we did in 2018 that looked at community-acquired pneumonia and UTI. Again, similar principle to really emphasize narrow spectrum cephalosporins. And here you can see that we looked at the narrow spectrum beta-lactams and the broad spectrum community acquired, and we saw that increase in the narrow spectrum agents and the decrease in broad spectrum over time. So this is where leveraging this data can be helpful, and this is an example on the AU website. So check that out if you want more info. Lastly, I'll just leave you with, this is our multi-drug resistant organism dashboard that I was talking about. So this was a multidisciplinary group to really track some of our trends throughout the hospital and outbreak concerns. So this we got from our AR isolates and the data that was uploaded, and then really just added things to it and manipulated some of the definitions. We included more organisms, but this allows us to track on a weekly basis kind of what the rates are for each of these agents. We can break it up by different infection sources. So we have things other than just our invasive and non-invasive. We have things like wounds, we have things like tissue culture. So all that information really allowed us to tailor kind of the data for use at NM. And those folks are listed here. So again, infection prevention and IT analysts really helped us a ton. So Grace, Asra, and Rachel. And this is where we used our rate tables. So this looks at kind of 10,000 patient days in the isolates to get a better sense of the trends over time. So trend lines here to track that resistance, to note any potential outbreaks. So we have it across really all of the various phenotypes and resistant groups. And then again, gives us a sense of how we're doing kind of throughout the years. So in summary, I think some of the best practices, find your resources and build your team. Really, this is going to be a long-term process. So continue to iterate, improve it as you gain experience and comfort. If you can, build some systems that are automated so you have to do less manual work. So Eric, I'm stealing kind of what you shared with us to really make that reporting and tracking more meaningful and have standardized processes where you can. The evaluation of the impact should be continuous as well to really inform other stakeholders and improve antibiotic stewardship interventions and practices, and then leverage that data and share your story. So again, make sure you're kind of sharing it with clinicians, sharing it with decision makers, sharing it with patients, and then within your networks as well, because the more knowledge sharing and transparency that we have, I think the better we'll be using this data and the kind of better care that we'll be providing, in addition to enhanced antimicrobial stewardship. So with that, I'll just leave you with some resources and thank a bunch of people. Obviously, thanks to all the planning committee, Shannon in particular, and apologies for the tech issues. Thanks for staying a minute over, and I'm happy to take any questions. All right, I know you want to go home, but any burning questions? Yeah.
You ever thought of using the NHSN data to augment surveillance of any nosocomial infection outbreaks that may be happening in the system?
This is exactly what we used this dashboard for. So especially we had concerns for an outbreak with Candida auris, and we were able to use this to identify it initially and track it over a few months. And then it led to us building an additional dashboard specifically focused at Candida auris with more details on patient transfers, who were the providing teams, what kind of procedures they had done. So yeah, this was fundamental, and we wouldn't have been able to do this without AR. So having that framework in place allowed us to really kind of build upon it and have a tailored approach for us at our institution.
Any deficiencies with the data that you saw?
It takes a lot of review, so especially because, again, that vendor piece and NHSN validate that all the information is talking appropriately and within that same channel. For us, we found that there were just irregularities that we didn't pick up on. So some of the resistance information with susceptibilities, maybe we found errors. Some of the things that we had initially said were non-invasive were marked as invasive. So things like a lower respiratory tract panel or sample was actually marked as invasive. So those things we've had to kind of evaluate and adjust over time. Yeah, sure. Yes.
Can you make a kind of broad comment about what's going to change with the new predictive model coming out?
I would have until I heard that there may be an additional 1,000 centers or locations added. So I think that will, you're increasing it by from 3,000 to 4,000 potentially. So I think there's no real way to predict. And as you saw, there's so many factors associated in that kind of calculation. The magnitude, I'd expect most of them will be similar, but the magnitude should be changing. Yeah, we'll see. 2025 is what I've been told. I don't know when the 2017 ones came out in terms of like which calendar month, but I would expect, hopefully in the first half of 2025, we'd see that data.
You're talking to the rebaselining?
Yeah.
Yeah.
Cool. Well, thank you all for sticking around and hope you have a nice afternoon. Thank you.